Welcome everyone. Thank you so much for joining us this afternoon at this special event with Dr. Tori Hudson. Thank you for joining us at this webinar. I am Amy Regan. I am a partner marketing specialist here at Fullscript, and we're very excited to have a presentation by Dr. Tori Hudson in collaboration with Nutritional Fundamentals for Health and a live Q&A session to discuss reproductive health and fertility. Before we get into the presentation, I wanted to give a reminder that this recording and slide deck will be sent to everyone who registered at a later time. So if you have to leave a little earlier or you just want to watch it again, you have access directly from your inbox. The recording and several Nutritional Fundamentals for Health resource handouts will also live on Fullscript's website at fullscript.com/webinars, where you can access all of our past and upcoming webinars. Please place any questions you have throughout the webinar in the questions box. Dr. Tori Hudson is a nationally recognized author, speaker, educator, researcher, clinician, and the first woman in the United States to become a full professor of naturopathic medicine. Dr. Tori Hudson has been in practice for more than 35 years. She is the medical director of her clinic, A Woman's Time, in Portland, and the founder and co-director of Naturopathic Education and Research Consortium, a nonprofit for accredited naturopathic residencies. In 1999, Dr. Hudson was awarded the prestigious Naturopathic Physician of the Year Award and 2003 NCNM Alumni Pioneer Award and the 2009 Natural Products Association and Northwest Pioneer Award, NW Pioneer Award. In 2012, she was inducted into the NCNM Hall of Fame. In 2016, she was the recipient of the annual Oregon Association of Naturopathic Physicians Living Legends Award. How lucky are we to have her here today? Dr. Hudson has served the National College of Naturopathic Medicine in many capacities, including professor, medical director, associate academic dean, and academic dean. She is currently the adjunct clinical professor at NUNM, Southwest College of Naturopathic Medicine, Bastyr University, and Canadian College of Naturopathic Medicine. Dr. Hudson is also the author of the Women's Encyclopedia of Natural Medicine and also serves on several editorial boards, advisory panels, and is a respected medical advisor to Nutritional Fundamentals for Health. Before we begin, please note this webinar was designed for practitioners and healthcare professionals in mind. With that being said, welcome, Dr. Hudson.
Thank you, Amy. Now that we've established that I'm old, we can go on to the younger sect and fertility, but thank you very much. I appreciate the opportunity with Fullscript and with NFH. Hi, everybody. Yeah, old. It's even older than she said. It's been over 38 years now. So this whole little shtick has been going on for a while. But I'm very privileged to be on the advisory board with NFH and have opportunities to participate in their robust educational content. And if you haven't signed up for some of that, you really ought to. NutriMedica, all that can be found on their website, signing up for their emails and their newsletters and their blogs and their content and their videos and their interviews. It's really, I think, the most extensive venue from a nutraceutical company that exists at the moment for all the amazing content that they have. Okay, I'm going to go in and out of my webcam so that I can just sort of focus a little bit more sometimes. So I think I'll leave it on for the moment. All right, let's see. Let's get, I think, full presentation mode. There we go. Okay, so disclosures, well, they didn't show up there on this slide. Oh, here they are. Fancy. I have to press the button more than once. So the most important disclosure is I am on the advisory board for Nutritional Fundamentals for Health, but I have some other disclosures as well, including being the co-owner of Vitanica. I want to thank Dr. Jody Peacock, who also is represents and is an educator for NFH, and Dr. Jacqueline Smeaton, also you might know her as Dr. Jacqueline Chassie, who also has some content on NutriMedica and associated with NFH. And I'm thanking them because I used their, I've been educated, I've been able to be in some of their presentations and learn from them, number one. And also Jody helped me out a lot with these slides, and I used just a few little slides from Jacqueline as well. So I wanted to start here because especially when we get into well, I don't know about especially, but anything that we might call women's health care these days, there is a lot that we now need to be more sensitive about in terms of pronouns. So I just want to read this to address that, because I will be using I will, yeah, I want to address that. I'm aware that the content of this webinar may include assumptions, making assumptions, and geared towards the use of the terms and pronouns such as she, her, women's health in women, and in the case of this webinar, in men as well. I've given this topic some considerable thought, and it comes with angst when I do think about it. Based on the experience that I have accumulated these last 38 years, my patient population, the body of research in the area of women's health and fertility, and the incomplete and dissatisfying and often equally exclusionary language alternatives at this time, I will be using the terminology of women's health care in women, in men. I really do apologize in advance for anyone feeling excluded. That is not my intention. I'd like to think that we all in attendance here are able to make the gender affinity associations that are most comfortable and relevant. I'd like to think that treating the individual is still our hallmark of a natural medicine philosophy, and I do reassure you that I have respect for transgender and non-binary individuals and the difficult process and decisions that have been made. I wish healing and safety and quality of life for all of us. Okay. It's been said that the current generation being born is the first in history that is not predicted to have a longer lifespan than their parents. Isn't that just sort of amazing to ponder that that could be true? But it is true, and disturbing. I want to use, this is something, a slide of Jacqueline's, by the way, and she recently did a seminar at did a lecture at my seminars, Institute of Women's Health and Integrative Medicine. And I thought, since we're not really talking about preconception here, I did just want to acknowledge that there is, unrelated to whether we know someone is fertility or is fertile or infertile, she wants to get pregnant. And if we are assuming fertility for the moment, I think it's ideal to do 6 months, or optimal. And if we can get 3 months, that's great in terms of preparation. And it's this would be her list, and I would agree with this list, and I would a good quality prenatal multivitamin, fish oil, vitamin D if needed. We can always test. Probiotic if needed. I would say now, based on the evolving area of the microbiome as it relates to the vagina, the uterus, the ovaries, the sperm, what else? All of this is now, it's a rapidly evolving area, is the role of the microbiome and all of this. Actually, semen, not sperm, the microbiome, and the oocyte, that we now should probably be giving probiotics preconception and during pregnancy. And Dr. Smeaton just gave a wonderful lecture at the NFH sponsored women's health event in the fall, and she gave the almost identical lecture at my fall event on the reproductive microbiome. And you start to realize, wow, this research is really evolving at a rapid pace, and you need to learn what are the sort of urogynecological specific species and strains, and that are relevant. And you can, I think, access her NFH related reproductive microbiome lecture. I'm pretty sure you can still access that. Studies have demonstrated that there's a significantly improved pregnancy rate in women who are on a simple multiple vitamin mineral supplement compared to if they were just on folic acid alone. And that's research is especially done with Clomid and without Clomid, and it's even a greater difference with after 3 Clomid supported cycles. The difference between a multivitamin versus just folic acid alone leads us to say, yikes, yeah, we need to think well beyond just folic acid. And I think most of us are, in terms of a good quality prenatal. So let's talk about, in this lecture though, we're going to address a few select items today, not all of them. And the one of them meaning we're not going to really talk about anovulation and insulin resistance and implantation in terms of the health of the endometrium. We're going to focus on quality of eggs. We're going to focus on the motility and mobility of sperm. So we're going to really focus in on this. And I dreamt about mitochondria all night last night, apparently, just in preparation for this. So the contributors to reduced quality of gametes, it seems to be the age of the female, but male as well, but especially female, inflammation, toxins, smoking, recreational prescription drugs, hormonal milieu, sedentary lifestyle, and poor diet. And, we're obviously, so egg quality, as I said, is the focus of this lecture, but we need to address also immunity, regular ovulation cycles, blood flow to support healthy implantation. We're going to talk about mitochondrial function. We need to optimize androgen levels in women. And we're going to talk a little bit about oxidative stress. So all of that is involved in supporting healthy pregnancy and optimal pregnancy. In male fertility support, we have similar goals, supporting sperm quality, addressing oxidative stress, mitochondrial function, and optimizing androgen levels. So things to consider for oocyte quality. As women age, there are really several influences that can have a negative impact on egg quality. One of them is a decrease in serum androgens. And then we're going to talk about this increased oxidative damage and increased mitochondrial stress. And as I mentioned, the microbiome of the oocyte and of so many other things involved as well in the reproductive system. So again, I would check out that lecture that NFH has on file on the reproductive microbiome and learn about those uro-GYN specific lactobacilli. Okay, so let's talk a little bit more about the mitochondria in the oocyte. So the embryo derives all of its mitochondria from the oocyte. And as the cell grows, that number of those mitochondria increases, and there's a peak at ovulation from 6,000 up to 300 to 400,000 mitochondria. And these mitochondria will be the only ones that are present in the embryo until after implantation. So those supporting that needed increase in maximal level is important. So that's why we're talking about it. And if we have healthy levels of mitochondria that are present, that'll lead to optimal ATP production and better quality embryos. So quality, enough mitochondria, quality oocytes, quality embryos. And they're important because mitochondrial DNA is quite a bit more susceptible to mutation. There's 10 to 20-fold higher rate of mutations in mitochondrial DNA than there is in nuclear DNA. And the mitochondria have a more difficult time undergoing repair. And as women get older, they're constantly exposed to these low levels of free radicals, and the mitochondria function leads to less ATP production, and that is even more important as women's fertility ages. As I mentioned, as she gets older, she's continually exposed to an accumulative effect of these low levels of free radicals. So impacting oocyte quality is an issue of not only nourishing the mitochondria, but improving the hormonal cycling, assuring ovulation, assuring adequate surges of estrogen and progesterone, and the proper buildup of the lining of the endometrium. And so it creates this optimal space for and place for implantation. So the optimizing the environment the oocyte grows in key. And we do that by reducing free radicals, nourishing mitochondria, and improving pelvic blood flow. We're not going to really talk about that today, improving pelvic blood flow in any detail, but I do have a slide towards the end that gives you some highlights around that. So let's start with CoQ10. So we know this is an antioxidant that scavenges free radicals. It prevents oxidation of lipids and proteins in cells, and it supports cellular energy production. There was a trial back in, I think, 2017. And these were women that did have PCOS, and they were given 100 milligrams a day of CoQ10 for 12 weeks. And what they saw was improved gene expression related to insulin, lipid metabolism, and inflammation. There was also another study at 60 milligrams a day for 51 patients and 82 ovulation cycles, and CoQ10 works synergistically with Clomid in improving ovulation and clinical pregnancy rates. So there was more ovulations and higher pregnancy rates when you did both together, the CoQ10 at 60 milligrams and the Clomid. And women diagnosed with poor ovarian response, even those under age 35, when they were given 200 milligrams of CoQ10 3 times a day for a couple months before IVF, they saw that more embryos survived to day 3, and no, so 8% in treatment group and no day embryos, and 20% in the placebo group. So more embryos survived in the treatment group. I'm not sure I stated that properly, but I think you get the drift. So acetyl L-carnitine is another antioxidant with protective effects on growing embryos. And how it works is acetyl L-carnitine transports long-chain fatty acids across the inner mitochondrial membrane and reverses that age-associated decline of the mitochondrial membrane potential, and then improves, or you might say diminishes, mitochondrial abnormalities. There was an experiment when they added acetyl L-carnitine to embryo cultures that they then challenged with oxidative stress. There was reduced DNA damage, and there was improvement in chromosomal structure and development of the blastocysts. So that's acetyl L-carnitine. And then there are some specific indications for acetyl L-carnitine and PCOS. There was a study of 27 non-obese PCOS women that found significantly low levels of L-carnitine and sex hormone binding globulin in PCOS patients compared to the healthy women that did not have PCOS. And with low levels of L-carnitine associated with hyperandrogenism and insulin resistance. So that is in these PCOS patients. That, as you know, is the two core issues in PCOS is hyperandrogenism and insulin resistance. So anything that we can do to counteract that, that is getting at the core of PCOS. In a randomized clinical trial of 85 Clomid resistant PCOS patients, so they were taking Clomid, it didn't get them more ovulation cycles, and when they then got 3 grams a day of L-carnitine in addition to the Clomid, they had results of improved ovulation, improved pregnancy rates, their body mass index went down, and improved lipid profiles. And that was compared to those who had just the Clomid alone. Okay, let's go on to PCOS unrelated to fertility and PCOS. So myo-inositol. So whether it's a PCOS woman unrelated to, I gotta advance my slide. I love inositols. I use them a significant amount in my practice. And I use it for PCOS patients. I use it for who don't, or unrelated to fertility. I use it for PCOS women seeking fertility, and I use it for non-PCOS patients seeking fertility. So there's 3 different populations there. So in the ovary, we find that inositol aids glucose uptake and the cellular energy status and improves FSH signaling, which then obviously would allow for better germ cell maturation. In PCOS women, it can restore regular ovulation and ovarian function. It can lower androgen levels, and it can improve insulin sensitivity. Those are all the things that we want. The improved oocyte quality was observed in 175 IVF participants who did have PCOS, and they were given 4 grams a day of myo-inositol from day 1 of their cycle to 14 days after embryo transfer. And the pregnancy rates in the myo-inositol, and then there was another group, myo-inositol with melatonin supplemented, were myo-inositol almost 37% and a little bit more like 41% in the combination group, compared to the controls without myo-inositol. So the pregnancy rate in those was 31%. So it's not huge, but you do get a bump, and you get even a little bit bigger bump when you add melatonin. Even 12 weeks at 2 grams per day of myo-inositol in 50 overweight PCOS patients reduced hyperinsulinemia, improved insulin sensitivity, restored their LH, prolactin, and testosterone levels. So 2 to 4 grams a day. I personally hunker down around 4 grams because I think most of the research and the best research is at 4 grams a day. In research in non-PCOS patients, as I mentioned, also relevant, we see concentrations of myo-inositol in the follicle seems to correlate with improved oocyte quality, and it plays a role in the oocyte maturation. We think it might play a role in implantation, and it reduces the amount of the gonadotropin medications that are needed to stimulate the ovaries, like that are used during IVF, and again, leading to higher pregnancy rates. Let's move on to alpha lipoic acid, another lipid-soluble antioxidant, improving glucose uptake, and it's likely that it's doing that via AMPK, which is how it helps endocrine and metabolic disorders. We're talking about activated protein kinase, or adenosine monophosphate activated protein kinase. That's the AMPK. In a study of 400 milligrams of ALA over 3 months in patients with PCOS and obesity, which is about maybe 50% of PCOS patients, there were improvements in metabolic parameters such as body mass index and insulin levels. If you use a combination of ALA along with myo-inositol, they did this in 36 obese PCOS patients, improved metabolic parameters and oocyte quality after 3 months. So again, we see some combinations having even a little bit better results than just one of these ingredients by itself. So vitamin E, another fat-soluble antioxidant. For women greater than 35 years of age, this seems to be important in particular. It improves the time to pregnancy for infertile couples over a range of doses. They've looked at an average dose was about 37 milligrams a day. And vitamin E has been associated with the number and size of eggs actually increasing. And in animal models, they've seen this as well. Vitamin E has also been shown to improve a thin endometrium. So when we're talking about Oh, an optimal endometrium for supporting implantation, we can think of vitamin E as well. And these were pretty much higher levels, 600 milligrams a day. I know that, we use melatonin. The list of therapeutic uses for melatonin is just growing exponentially, it seems. I don't know, tinnitus, migraines. I'm sure, we have all our insomnia, jet lag stuff, fertility, immunity, a lot of buzz around it and related to SARS-CoV-2. The list is long. But if you, endometriosis, that's kind of probably my most, outside of insomnia, that's my most common use of melatonin, is endometriosis at 10 milligrams a day. All right, let's go back to the topic at hand though. In its role as a reproductive antioxidant, the melatonin actually concentrates in the follicular fluid. It regulates the circadian rhythm, and so then we know just her sleep cycle and her stress levels then are more optimal for fertility. We know that the production of melatonin decreases as we get older. And in 4 human clinical trials with melatonin and IVF and ICSI, ICSI is that's called intracytoplasmic sperm injection. So it's an added feature of IVF where they're actually, putting a sperm into the location specific egg that they want. In 4 human clinical trials with the combination, there was a statistically significant increase in the number of mature oocytes and the statistically significant number in high quality embryos. And then several studies have looked again at this combination of myo-inositol with melatonin. And there are, of course, natural ways to support melatonin. I love this concept of there is an increasing darkness deficiency going on in our world, and we don't have enough darkness, and we need enough darkness to produce to have natural endogenous adequate levels of melatonin secretion. So we need to teach our patients how to have adequate darkness and minimizing blue light from all the devices, consistent bedtime wake time schedules, and a completely dark sleep space. Here's a little factoid related to myself, which is, rarely all that useful, but it might be useful to share it right now. This concept of completely dark space. I live out in the country, surrounded by forests, lots of natural, the light, the night sky. But my house is out in kind of the middle of nowheresville and no neighbors right around. And so I do have security lights on the outside, and one of them is in the back porch, which is right below my bedroom. And there's even a roof over that back porch light, but still that light spreads out, and it does make my bedroom have a different level of light than if there was not. And I get enough sleep, but I have interrupted sleep, and it works out. But I was just curious if it would make a difference if I turned out that back porch light, and I'm on the second story, and again the light it's not going directly up, it's going out and up. And sure enough, when I leave that light off, I don't wake up as often during the night. So, and that's in a place that's already pretty darn dark and doesn't have any other street lights and such going on, and I have no devices. So I was curious to see if it would make a difference for me, and I'm convinced that it does. So thanks for listening to that little tidbit. Let's move on to our friends, the mighty sperm. So sperm health has to do with the total number of sperm, how well the sperm can swim and move around, how they look, their pH, how acidic or alkaline the environment, the total volume of fluid, how sticky they are, and an MIR test, looks at antibodies. A normal average count is 60 million, and it gets flagged if it's below 15 million. And there are numerous causes of low sperm count that men have to face these days. Stress being right up there on the list. Excessive exercise. This is not the only, this shows up in women's reproductive health as well. Excessive exercise along with low body weight is a challenge to the reproductive cycle. In men, it's just the excessive exercise. Toxins, steroid and recreational drugs, genetic influences, previous damage or surgery, infections. There is, NFH also just, I think, I don't know if it was 3 parts or one part, maybe Crystal can tell us, but there is actually the crisis in male fertility. NFH just did a show on this through NutriMedica with Dr. Smeaton and Dr. Peacock that is supposed to be really excellent. And to show you how important it was labeled the crisis in male fertility. So this topic is important, and we're going to cover it a little bit here. So let's talk about sperm mobility. There are 2 things to assess: the number of sperm that are actually moving, that should be at least 40%, and then the number of sperm that are moving forward, and that's towards their goal. It reminds me of that movie with Kirstie Alley and what was his name? The Cheers guy. Anyway, I think it was called Looking Up, and the intro to it. If I was really thinking ahead, I would have played that for you right now. It's a great little thing. I think Bruce Willis is the narrator talking about the sperm trying to find its way and everything. It's quite funny, and I regret that I'm not showing it to you. Anyway, poor quality. The causes of poor motility are the same as poor sperm count as well, in addition to, so same things here, but also in addition, we have things like zinc deficiency and defects in the tails and the longer length of time between ejaculations. And we have a great research showing lifestyle and diet can improve sperm motility. So I urge you to be familiar with that. Let's talk about acetyl L-carnitine. It's found in the highest concentration in the epididymis and plays a major role in the energy metabolism and how those sperm mature. A deficiency can reduce fatty acid concentrations within our friends, the mitochondria, and leads to concerns with the actual sperm motility. There's also a positive correlation between free L-carnitine and both sperm count and sperm motility, and this was established in a study back in the 1980s. In one study, there was a small study, 20 patients with abnormal sperm were treated with 4 grams a day of acetyl L-carnitine for 60 days. 60% of the patients had an increase in their progressive sperm motility. 4 months after the therapy stopped, the sperm returned to their preterm baseline. So you have to sustain that to get that sustained level of motility. You have to sustain the supplementation. NAC, one of my absolute top of the list, very favorite multi-use supplements in women's health and primary care. And here we have it as an antioxidant it works by bringing a precursor of glutathione peroxidase. I think you all know that. But there were 2 studies that looked at NAC and sperm parameters given a familiar dose, 600 milligrams a day for 26 weeks and 13 weeks. Both studies, so 2 different studies, one longer, one shorter. Both of those studies demonstrated an improvement in sperm motility. However, only the one study, which is at the 600 milligrams a day for 26 weeks, had an increase in sperm concentration and morphology. Taking a little drink of my iced tea here. All right, let's move on to coenzyme Q10. Another fabulous antioxidant needed for cellular respiration. In a double-blind study, coenzyme Q10 at 200 milligrams a day in 60 men with this idiopathic abnormal sperm morphology and reduced motility for 6 months improved sperm motility, and there were 12 spontaneous pregnancies that occurred. There was another study in almost 230 infertile men at 28 weeks, and sperm count again improved, motility improved, morphology improved, count improved, all of it improved with coenzyme Q10. I'm not actually sure if that was the same dose or not, but let's assume, let's go for at least 200 milligrams. And there are numerous other studies on coenzyme Q10 that support this beneficial effect in improving sperm parameters, motility, count, morphology. And let's look at folate and B12. We know that B12 is instrumental in RNA and DNA synthesis. Lower B12 levels have been associated with decreased sperm counts and motility. Super simple thing to test, right? Methylcobalamin at 1,500 micrograms a day in infertile men for as little as 2 months up to a little bit more than a year resulted in significant improvement in sperm parameters. And then they did a separate study at 1,000 micrograms a day in men just for lower sperm counts, and again, improved sperm counts with just a simple B12 1,000 micrograms a day. But we know that abnormal folate metabolism is also a factor that can contribute to male infertility. We might want to increase our testing of MTHFR for male infertility because that can contribute to DNA fragmentation and infertility. Vitamin C, a water-soluble antioxidant. It's found in high concentrations in seminal plasma. Vitamin C alone, along with either alone or in combination with other antioxidants, can improve sperm quality and reduce damage to the sperm. Vitamin E, a fat-soluble vitamin and antioxidant, has been shown to significantly decrease levels of lipid peroxidation in seminal plasma and improve their motility. And then we have selenium. If you add selenium with vitamin E, you can also significantly increase sperm motility and overall percentage of normal sperm. So all 3 of these antioxidants have a role, and I say, why not just do all of them? Selenium in particular, though, is needed for testosterone biosynthesis and sperm formation and the actual integrity of the structure of the sperm. It improves sperm counts, sperm concentration, their motility, their morphology, all in infertile men. Especially if you use it in combination with NAC and vitamin E. Let's go back to our NAC for a moment, reminding us that it improves numerous sperm parameters, including motility and morphology. Zinc, super crucial for normal reproductive male reproductive system. A zinc deficiency can be related to lower testosterone levels and sperm counts. Zinc is like a must-have for the proper motility of the sperm and the proper production of the sperm. In studies at 24 and 89 milligrams a day of elemental zinc showed increases in testosterone levels and sperm counts along with successful pregnancies. Now, just a reminder, right, when we're doing this kind of supplementation of zinc, they need to either be on a multi with copper or add, tiny bit of copper to their supplementation. I vote multi to the men because we don't want to create a copper deficiency, which then can be related to other problems on down the road. And we're going to be potentially doing this for months or even well, at least months and possibly years of this supplementation of zinc. So that becomes important. It's well known that numerous lifestyle things impact sperm, as I mentioned earlier. Cannabis use more than once a week was associated with 28% lower sperm concentrations and 29% lower sperm counts. And a combined use of cannabis more than once a week and other recreational drugs had an even more harmful effect, even greater, more than twice the drop of sperm concentration and sperm counts. Alcohol and cigarette smoking also have negative impacts on fertility. We know that there can be impacts on oxidative stress, enzymatic antioxidant activity, and effect on DNA damage. 108 male infertile patients with normal ranges of sperm conventional parameters but with unexplained infertility were divided up into 4 groups. There was the control group, which was non-alcohol and non-smoker males. Then there was the alcohol group, then there was a smoking group, and then there was the combo, the twofer alcohol smoking group. The last 3 groups, whether it's alcohol alone, smoking alone, or the combination, compared to the control, had an increase in oxidative stress and DNA damage higher in the smoking and alcohol smoking group. And the alcohol smoking group also had higher rates of DNA fragmentation. So smoking, the worst. Alcohol smoking, the worst. Smoking and alcohol intake lead to unbalanced antioxidant oxidation ratios with oxidative stress leading to damage to the sperm. And then we have all this was a lead up to share with you the NFH formulations for male fertility and for egg quality. And so you see in the male fertility formula, we see everything that we talked about, I think. Of course, when you put multiple ingredients in a formula, you don't have the high research dose of a single ingredient, but you can punctuate where you see fit. And you can also look to NFH for these items in individual form. So we see the N-acetyl, the carnitine, the cysteine, the CoQ10, the other antioxidants, the C's, the selenium, and then that some zinc, and they already took care of the chromium for us. Thank you very much, NFH, and then B12 and folate. In our egg quality formula, we see, again, things that we've talked about. We see the inositol, the lipoic acid, the NAC, the L-carnitine, and the CoQ10, along with some mixed tocopherols and vitamin C. So those are the 2 focused male fertility products and egg quality products from NFH. And you can look to, again, NFH if you have a PCOS patients. They have an inositol formula. They have NAC. Trying to think of, well, of course, they have vitamin C and mixed tocopherols and CoQ10 by itself as well. So like I said, you can punctuate where you see fit. And I would say for the female side, you're going to commonly be punctuating with inositol and acetylcysteine. I have a few more slides here. These were thanks to Dr. Smeaton. Just that we talked about androgen, but there are androgens that are, PCOS obviously is the hyperandrogenism issue that we don't want. But other than that, we know that androgens are important for egg quality as well as sperm health. And there's some of you are probably familiar with a little bit of research on DHEA supplementation to improve egg health. And I'm actually not quite sure if the Health Canada allows dietary supplements of DHEA or not. But also tribulus, maca, especially certain phenotypes of maca, do support androgens in females. For males, also tribulus, maca, actually not familiar with that, probably East Indian herb, shilajit, saw palmetto. Those are some common things we can look to. And then there's some other important considerations that I alluded to earlier, supporting implantation, reducing inflammation, and the microbiome support. In terms of improving blood flow to the uterus and specifically the endometrium, you can think about maybe some of these dietary influences, because nitric oxide can support optimal blood flow to the male and female reproductive system. And there's actually an upregulation of nitric acid at the implantation sites. So think pomegranate, the forbidden fruit of Persephone, who had to keep going back to the underworld because she ate the pomegranate while she was kept there by Hades, and that's apparently why we have winter, as she had to go back there seasonally as her sort of punishment because she'd eaten the pomegranate. And then some of you are probably dual licensed or only licensed in acupuncture, and there's a huge role of acupuncture in infertility, at least in females, and especially some protocols in companionship with IVF. Inflammation, you know, lots of reasons to give omega-3s to a pregnant woman. Not specifically related to improving her fertility, but certainly related to improving the optimal duration of her pregnancy, as well as the health of the fetus and the infant. But you can also be incorporating curcumin, bromelain, quercetin, and resveratrol. And fish oils derivatives particularly seem to have powerful effects on chronic inflammation, these specialized pro-resolving mediators. Okay, and here's a little punchline with the vast amount of research focused on improving the health of both oocyte and sperm. As naturopathic physicians, as integrative physicians, as alternative medicine providers, we can educate our patients preconceptually and pregnancy to optimize pregnancy, healthy pregnancies, healthy babies, healthy people. All right, I think that is the end of our presentation. And here's some references. I guess you'll get those slides. And maybe you'll have some questions and maybe I can answer them. Let's see what we've got going here. Let's see, my webcam, no one can see you. You can now though, okay.
Now we can see you. Excellent. Thank you so much, Dr. Hudson, for that incredibly engaging and informative presentation. So we did have a number of questions come through. So let's spend the next 10 or 15 minutes going through them.
Okay.
And I'm going to help facilitate with that. So I'm just going to start at the top of my list. We had a number coming.
Okay, make sure they're easy, Amy. Make sure they're
okay.
easy. Okay.
I definitely will try.
I haven't had my lunch yet. Okay.
Here's an easy one. What is your favorite brand of prenatal vitamin?
Okay, you guys, NFH is sponsoring this webinar. Need I say more? But there are, you know, there are a lot of good ones out there, and you know, you want to just pay attention, you know, how much vitamin A is in there, how much folic acid is in there, how much, you know, zinc, selenium, vitamin E, vitamin C. Just pay attention, and pay attention to the dosing. And because some generally, if it says just take one a day as a prenatal, I'm gonna really look at that label closely to see if it really does. It's not going to have the optimal levels of everything that I want to be optimal, because they just can't stuff that much in a capsule and in a tablet. So that's why often with a prenatal, you're going to see the full optimal maximum dosing during pregnancy is actually 2 capsules 3 times a day. And I'm actually not familiar enough off the top of my head with the NFH prenatal, which I assume they have. But Crystal, yes, could you chime in? Is there an NFH prenatal? But Crystal did say she loves the movie Look Who's Talking. Oh yeah, I might have said Looking Up. Look Who's Talking. That is the name of the movie. Thank you so much, Crystal. Super fun. Okay, next question, and maybe she'll
Next
chime in, and maybe you
question.
can tell us what she says, Amy.
Definitely, definitely. Okay, so we have a question here that asks, how far in advance of attempting pregnancy would you recommend males start taking male fertility SAP?
I would say minimum 3 months. I would say more optimal 6.
Okay.
But anything you can get is an advantage. Anything you can get.
Excellent.
Crystal, what we needed from you is, does indeed NFH have a prenatal vitamin? All right, Amy.
Yep.
Your turn.
Okay, the next question, yes, and NFH does have the prenatal vitamin. I'm just hearing from Crystal. Yes, we do. Okay, and we can get a link to that. I'll send that to everybody after the presentation. So the next question we have is, do you have concerns about taking probiotics during pregnancy, given the 2021 CORAIN review linking probiotic use with increased risk of preeclampsia? And obviously there needs to be more studies on this, but we were interested in your thoughts.
Yeah, I'll check out that study, but you got to look. The research is overwhelming on specific species, so I would go back and look at what species are and strains, but more especially species were in that probiotic. It might have just been a routine probiotic for gut, not one for the reproductive tract. And so the dominant species that you want to see is Lactobacillus crispatus. You want to see crispatus, gasseri, Jensenii, rhamnosus and reuteri. That's especially around preventing or treating bacterial vaginosis. But I would need to go and look and see what species was in that.
Makes sense. A couple questions about melatonin. Should melatonin always be taken at night?
Well, yes, but at night what that means is variable. There are situations where you need to move the melatonin earlier, and that's for people who have abnormal awakening responses and abnormal falling asleep times and wacky circadian rhythms. But one way or another, it's in the evening, but it's not necessarily right before bed at all.
Excellent.
So
Another
yes, for
question.
endometriosis or in these infertility support, egg quality support, I would go in the evening for sure.
Okay, excellent. And let's see. We have another question about melatonin. They're curious about melatonin as they thought this could actually impair ovulation or dysregulate the menstrual cycle.
I think I'm familiar with what that person is referring to, and so there's the sweet spot, right? Not too much, not too little. But melatonin can be used to optimize the menstrual cycle. I have people on high doses of melatonin sometimes, meaning like 6, 10, even 20 milligrams a day. Knock on wood, I have yet to see anybody's menstrual cycle disrupted by that. So I would probably look for another cause if there was an abnormality in their menstrual cycle.
Okay. Let's see here. The next question that we have is someone who has a patient with 20 to 32 day cycles, normal BMI, low AMH for her age, normal blood sugar.
How old is she? Does she say how old she is?
Let me see. I don't see how old this person is.
So 20 to 32 day cycles.
Yes.
Low MH for her age. Okay.
Yes.
But we don't know what her age is. Okay.
We
Low
don't know what
blood
her age
sugar.
is. Low blood sugar, or normal blood sugar, I should say.
No.
Low to normal insulin. And they gave her 4 grams of inositol, and that's what the question is about. And it seems to have made her cycles more irregular. Now her cycles are longer. The last cycles have been 40, 20, 42, 37 days. So wondering if you've ever seen that link between inositol and the cycle length.
Well, I would go back a bit, and you know, I'm not sure that that person has answered the question first, which is, why does this woman have frequent or irregular menstrual cycles? And so I would want, before I would not just be jumping to myo-inositol. We need to answer the question, why? And I don't think, from the information that they gave us, we haven't answered that question. So I would say that. So it seems to be lowering her androgen levels with inositol seems to have been the wrong thing to do, because you need androgens to make estrogen. So I can see why it may have been counterproductive, so I think it goes back to, why does this woman have this problem? And we need to go through our algorithm to diagnose that.
I see. So I'm just hearing now that that woman is 29 and TTC. And
TTC?
Yes, TTC.
Do we know what that means?
I'm not sure. Maybe they can fill us in the question box here. Excellent.
TC.
Okay.
Oh, okay.
Sorry. Trying to conceive. There we go.
I was trying to go with some gender thing, but
right?
Okay.
Doing the same thing. Excellent. So we have another question about melatonin. So would you still recommend melatonin outside of the IVF context, just in general?
I mean, for any reason?
Yes.
Or yeah. I mean, or are they saying specifically for fertility? I'm not sure what they're saying, but I read the question again, Amy.
They are wondering if you would still recommend melatonin outside of the IVF context.
Yes.
So, okay, excellent. Excellent. So the next question we have is, some female fertility projects have only D-chiro-inositol by itself. What's the daily dose if that's used by itself? Some physicians say this has to be combined with myo-inositol. Should we take it by itself or with myo-inositol, and what would the doses be there?
Yeah, you have research on both, and you have research on combinations. I personally am drawn to the combination, and there's some, I think you get kind of the optimum benefits and minimizing any downside by doing that combination. And I believe it's sort of 400 to 1. And I'm looking at, I know that NFH it's just inositol by itself, I believe, meaning myo-inositol. Someone can correct me, but I'm familiar with a product that has 4,000 myo-inositol and 100 D-chiro, and that is the sort of the most common, I think, blend that you would see out there in the fertility world.
Okay, excellent. Next question that we have is, what's the recommended daily dose of N-acetylcysteine for women trying to conceive? Some physicians recommend minimum 600 milligrams a day. Since it's excuse my pronunciation here, but eucolonic, can it cause a lot of side effects like dry eye? I noticed a lot of products contain way less than 600 milligrams.
Right, and let me just, I'm going to go to, so again, when you do have a product that is a common multi-ingredient, multifactorial supplement, and they're trying to ride the wave of the advantages to all the ingredients, you're going to see a lower amount of most of the individual ingredients. If you were using NIC by itself, for example, in PCOS patients, whether infertile PCOS patient or not, most of the research is 600 milligrams 3 times a day. So, for example, if you had, you could again, for egg quality, you could take she could take the oocyte SAP product from NFH, but if she had also had PCOS and we have more issues at play other than just egg quality with her, I would be adding NAC and I would be adding more inositol than what's in that oocyte formula because we're trying to improve insulin sensitivity, uh, have anti-androgen effects. So that's why adding more NIC and adding inositol is going to be important for the PCOS infertile patient.
Which form of CoQ10 do you recommend?
You know, I claim confusion myself on this, and I do think Jacqueline was asked this recently, and she said, you know, most of the research is done on the non-fancy form of coenzyme Q10, but we all talk about the fancy form, but most of the research is just, it doesn't have to be anything fancy, apparently, to work.
Excellent. So we are at time, but we do still have a couple more questions if we can just keep you for a little bit longer.
Sure.
Does that sound
Sure.
okay? All right.
I'll try, yeah.
Thank you. Okay, so are there any side effects to watch for when taking 3 grams of acetyl L-carnitine?
I'd have to look that up.
Okay.
But it does remind me that the previous person asked about NAC and do I see a lot of side effects from that? I don't hardly ever see side effects from that 500-600 milligrams 3 times a day. On rare occasion, I mean, 1 out of 100, some nausea could occur. Or at least that's what I've seen when there has been a side effect. But it's, excuse me, it's not very often.
Okay. Let's see. What's the daily dose of L-acetyl L-carnitine and glutathione to help men with fertility? What's your intake on using Relora as a Magnolia Officinae Spark extract to help with stress for men and to help with fertility as well?
So that was the first question. That was hopefully not all one question, but acetyl L-carnitine, it looks like I was looking back at that slide. Did they have doses 4 grams a day of acetyl L-carnitine? And then I think, you know, numerous lifestyle, counseling, Mother Nature, herbs, nutrients can help with managing stress, and that Relora is one of those. The magnolia and I think there's another plant in there. It wouldn't, you know, I would be probably more prone for men to be thinking of adaptogens that could also support their androgens. So I might be thinking of ginseng, for example. And you almost can never go wrong with ashwagandha, women and men. I think that's the best I can do to answer that question.
Excellent, thank you. So the next question we have is, when testing serum B12 in men, what would be the optimal levels for males? Please provide the units as well. Very specific.
I am not, you're going to end on this question. I am not going to be able to.
Okay.
I'd be looking that up, and hopefully that, you know, that is, there's no shame in that, in whether you're with a patient, not with a patient, giving a lecture, there's no shame in, oh, I need to look that up to see what is, because it depends, and if you've noticed, it's not just the units, and I'm glad that person caught that, because that drives me crazy around vitamin D. What units are we talking about that we're using as a reference range? We read these studies on such and such a level, but that was a different unit than our lab is actually measuring. So I'm glad they're onto that. But and different labs have even different reference ranges, and that's a bit irritating. So I don't have the specific answer, but so I would have to be looking that up, and I'm sure it's an easy look.
Excellent. Well, I want to say thank you so much for this wonderful presentation. This is a good spot to end. And let me just pull one thing up right here. Excellent. So I want to say thank you so much to Nutritional Fundamentals for Health for this great presentation and for being here with us today, Dr. Hudson. Once again, a quick reminder that you will all receive a copy of this recording in your inbox, along with the slide deck and handouts sometime late this week or early next week. You can find all of our webinars on fullscript.com/webinars. So thank you again, everyone, and we hope to see you next time. Didn't know if you had any closing remarks, Dr. Tori, but I wanted to just ask.
I have, thank you. Thank you to NFH, they're a fabulous group of people to work with. It doesn't get any better than what they have going on over there. And it's not just that they're Canadian. They're just smart, kind, competent, generous people. And then the only other thing that comes to my mind that I want to close with one word is trees. Just save the trees, get to the trees, be with the trees, tell your patients about the trees, go be with the trees ourselves. So trees.
I love that.
That's it for me, Amy.
Thank you so much, Dr. Hudson, and everybody enjoy their afternoon.
Bye-bye.
Bye.